Welcome to Insights from Dementia Support Australia. I'm Marie Alford. I'm the Head of Business Development here at the Dementia Centre HammondCare, and I've got with me my colleague Tom Morris. Tom, your role?
Hi, I'm Service Manager of Research and Information, also at the Dementia Centre.
We're going to have a chat with you today about the Dementia Support Australia program and what we've done over the last couple of years. So just as a refresher to who we are for those from overseas who might not know much about us, we're a government-funded program funded by the Australian Commonwealth Government that delivers both the Dementia Behaviour Management Advisory Service and the Severe Behaviour Response teams. And as of late last year, we integrated the Needs-Based Assessment program, which determines eligibility for the Specialist Dementia Care programs. In essence, all these three programs support people where behaviours are impacting on their care. Our model is underpinned by a range of key domains. These include tailored and individual advice, ensuring that each person with dementia is assessed individually, and the recommendations and strategies that we provide are individually provided to the referrer. We also have associate specialists in our team, so a range of psychogeriatricians and geriatricians who support our multidisciplinary team of mental health nurses, registered nurses, allied health staff, and other aged care staff to provide behaviour support across the country. We're a national borderless service, so it's important for us to be on the ground anywhere in Australia within around 48 hours to a week, depending on the risk associated with the referral. And we also seek to build capacity in the aged care sector. So it's really important in the recommendations that we deliver that we're able to support care homes to learn from what we're doing and provide additional support into the future for other people living with dementia. So Tom, one of the key things for us is the equality of access for clients. So do you want to talk me through what's happened since we started in October 2016?
Well, since that time, we have seen a very significant rise in the number of referrals that we've supported across both the DVMAS and the SBRT programs. In 2017, we saw a very impressive number of around 6,500 people with dementia. And then in 2020, we expect to double that and see between 11,500 and 12,000, a very large increase that we see no signs of it slowing.
That's fantastic. I guess it's important for us to think about, we were never designed to see every aged care home or every person living with dementia where behaviour impacts on their care, but we've been in about 76% of care homes across Australia.
I think as of today, it's just under 80%.
Wow, that's a phenomenal number of care homes. I guess we wonder what's happening in those other 20%. They might already have really good behaviour support systems or other services that are supporting them. But it's a good reminder to people that we're accessible and you can reach out to us at any time. So take us through what the average DVMAS client looks like.
Well, the average or typical DVMAS client is slightly older than an SBRT client, and they're more likely to be female. They're more likely to have a diagnosis of Alzheimer's disease, and they're more likely to be based in residential aged care. One of the reasons they're more likely to be based in residential aged care is because transitioning into an aged care home is one of the primary, is determined in part based on the presence of behaviour.
And the difference between the DVMAS and the SBRT, Severe Behaviour Response Team client profile?
So because those people have typically more severe behaviours that place other people at risk or themselves at risk, they're more likely to be slightly younger, they're more likely to be more male, and they almost exclusively are always based in residential aged care.
And whilst some of them have a diagnosis of Alzheimer's disease, what are some of the other things that we see more frequently in that cohort?
Yeah, we see a whole range of different diagnoses of dementia, Lewy body disease, dementia in the context of Parkinson's disease, and frontotemporal dementia.
So it's really important in our service that we understand the reasons for the behaviours that are being referred into us, because a person living with dementia isn't the behaviour that you see. So talk me through what we find when we actually assess people. What's actually the causes of the behaviours?
Yes, so we do look for all the causes that might be leading to behaviour. And I think right now we have up to maybe 60 that we have identified that may lead to behaviour down the road. What you see at the bottom of this slide are the three primary causes of behaviour as observed by DSA consultants. Unfortunately, number one, we have pain in almost 60% of all clients supported by DSA, and that might be mismanaged pain or undiagnosed pain. The next most common is the carer approach that client receives, and that is because it might not necessarily fit their routine or their personal preferences. A good example would be if I'm a late riser, my whole life I've been a late riser, and then I enter residential aged care, and I get woken up every day pretty early in the morning for breakfast. I might get a little bit frustrated, and over time that might lead to some more aggressive behaviours. The third most common is the presence of mood, such as depressed symptomatology or some type of anxiety.
And what are the three boxes along the top? Aggression, irritability, and depression. What do they tell us?
Well, as part of routine service provision of DSA, we administer the standardised, reliable and valid measurement of behaviour, the neuropsychiatric inventory. And what that shows is the three primary behaviours exhibited by clients supported by DSA include aggression and agitation, irritability and depression.
So Tom, talk me through Daniel's story. What happened for Daniel?
So the last slide was, it demonstrated that pain is quite common in people supported by DSA, and the case of Daniel really speaks to that circumstance. So Daniel was a 92-year-old gentleman with Alzheimer's disease who was referred to DSA because he was becoming increasingly aggressive and agitated towards aged care staff and other residents in aged care home. Daniel was referred to DSA, and a consultant went and visited Daniel on site and identified among a range of different things that it looked like Daniel might be in pain. So that consultant utilised another measurement that we use in DSA, which is another reliable and valid tool that investigates the presence and severity of pain, named Pain Check. And this tool revealed that it did look like Daniel was in pain and quite severe pain. So that consultant provided a range of recommendations surrounding that outcome, including doing regular pain assessments to the aged care home, but also recruited the input of a DSA clinical associate. Clinical associates, as you mentioned earlier on, are medical doctors who give specialist advice in particularly complex cases or cases where medications might be involved, either inappropriate prescribing or where prescribing might be optimized. So the clinical associate reviewed the case and identified that Daniel probably would benefit from some type of opiate analgesia and recommended that to Daniel's GP. And that's exactly what happened. And taking the DSA recommendations and the clinical associate recommendations on board, the referrer found that Daniel's behaviour returned very quickly to what they were like a few weeks prior.
And pain is something we see quite often in DSA, and it's really important. What we encourage aged care providers before they contact our service is to make sure they've undertaken a pain assessment, because we know that people with dementia don't necessarily express their pain in the same way that you and I might. So it's a really important issue to consider, along with a range of other tools like delirium screens, and really understanding and mapping the behaviour and what happened in the days before and the days after. So it's a great case study showing the effectiveness of taking the time to understand. We understand that care staff don't always have that amount of time to spend with each person they care for, because there's a lot going on across the day. So our consultants are able to be on the ground and spend a lot more time observing and understanding, but also supporting the staff next time to perhaps consider pain when behaviours change for a person living with dementia. So talking about the neuropsychiatric inventory and what we do, we also look at how we evaluate the impact of our service. So take us through this slide.
Okay, so as I mentioned just before, we routinely administer the neuropsychiatric inventory at intake, just so we can better understand and characterise the behaviours of the people that we support. But we also do the same thing around the time that we close the case, just to see what the impacts of DSA are and to use that information in the future to help refine our services and to better the lives of everyone living with dementia. And what we find based on the changes from that intake period to the case closure period is that there is a quite dramatic reduction in behaviour. We see around a 44% reduction in the total number of behaviours, and the NPI measures 12 different behaviours and psychological symptoms commonly seen in dementia. We see a 60% reduction in the overall severity of those behaviours and a quite large 64% reduction in the distress or disruptiveness those behaviours might cause carers and care staff.
There's some great outcomes, but I guess it's important for us to recognise that not all behaviours are resolvable, and resolving behaviour may mean a small change in what's actually happening for the person. But there are some intractable behaviours that occur, and I think some of our colleagues are talking about the needs-based assessment program, which determines eligibility for the specialist dementia care program. That's a particularly important part of our service where those behaviours are intractable, and that service can support that. So I encourage you, if you haven't seen that video, to have a look at that one. So we've talked about those outcomes. What about medications? I guess people often ask us, are we achieving these changes with increasing psychotropics? And that's a big topic in terms of the media at the moment.
Yes, definitely. And it's really important for us to make sure that that's definitely not the case, and that referrers aren't also perhaps achieving reductions in behaviour, as we just talked about on the last slide, in the presence of some type of change in pharmacotherapy. So we, on occasion, run audits of the medications prescribed to DSA clients, again at those same periods, at the intake period and around the time of case closure, just to see if there are any changes in prescribing of psychotropic medications. And what we routinely find, and this information on this slide is from a subsample of DB-MAS clients, that there's no change in opioid analgesia, there's no change in anxiolytic prescribing, but we commonly see a reduction, and that's fantastic, in the prescription of the often harmful antipsychotics.
And I certainly know that our associate specialists, our psychogeriatricians and geriatricians, do more de-prescribing than they do prescribing. So that's fantastic news in reducing the medication load of antipsychotics on our clients. So last year we started some work with KPMG that looked at the economic impacts of DSA. Talk us through this slide.
Okay, so this slide has a lot of economic speak in it, so I'll run through it a little bit. So an economic evaluation of any health service evaluates a few different things. One thing that is involved in that process is an incremental cost effectiveness ratio, and that's kind of what you see on the left. And basically what this process involves is evaluating a program in reference to similar programs or health services that exist anywhere in the world. And the health service being evaluated can fall really into any one of those four quadrants. A, you're delivering very successful results, but it might be slightly more costly than other interventions. B, you are delivering those results, they're very impressive, they're very large, they're better than other programs, and they're actually cheaper to deliver. That's fantastic. Yeah. If you were any service in the world, that's where you want to sit, and in terms of economic terms, you'd call that a dominant intervention. And then C and D, you don't necessarily want to fall into. That's because you're either less efficacious than other programs, or you're both less efficacious and more costly.
Right.
So what this evaluation found was that DB-MAS actually fits in that B box. It delivers very substantial reductions to behaviour compared to other programs and is more economical to deliver those outcomes. But sometimes that's not always possible, especially when the cohort being supported is especially severe or needs very timely support. And that's where SBRT falls into that A category. But importantly, they might be more costly to deliver that. But compared to all programs that could be identified as part of this economic evaluation, and even compared to DB-MAS, SBRT achieves the largest reduction in behaviour.
And I remember when we were doing this study, there weren't any other comparable programs to the severe behaviour response team around the world. DBMAS, there were some small programs with elements, but SBRT was quite unique in the Australian context.
Yes, that, SBRT falling into that progeny is definitely impacted by a lack of comparative programs, and there was a bit of guessing that had to be involved to be able to achieve these estimates.
So talking about cost savings, and we talked about SBRTs being having more change. What does it mean on the government purse and the state-funded purses?
Yeah, it's a really good question. So it's unknown whether or not behaviour support programs like DSA do have any type of downstream health service utilisation benefits. And so that's another significant component of an economic evaluation. And what this economic evaluation found was that DBMAS saves around $36 million every year in downstream health service utilisation. So, people are going to be hospitalised less, they're going to be using those services less because of DBMAS. And SBRT, it saves about $5.3 million every single year. So collectively, that's around $40 million saved every year because of the DBMAS and SBRT programs.
And so that has an impact in Australia on both of our federal Commonwealth government services as well as our state-funded services. And I guess for us, one of our key things is to keep people out of hospital, because it's not a good place for people living with dementia. And if we can keep them in their residence, whether it's at home or in the aged care home that they're residing in, rather than transferring them to hospital, sometimes necessary if they're clinically unwell. But if it's for reasons relating to their behaviour, if we can support them on the ground, that's fantastic for everyone involved. The cost savings are great, but more importantly, the quality of life for the person with dementia. So that's a great outcome. So we're in the middle of the pandemic. It would probably be wrong of us not to talk about what we've done. Have we seen much change in our service during the current pandemic?
Not really. We saw a slight dip, I think, in referrals as people, scrambled to adjust to the announcements made by the Prime Minister in around mid to late March.
Yeah.
But that resolved very quickly, and if anything, we're seeing unprecedented referral rates to DSA. I think especially because people realise how important it is right now to support people, especially in residential aged care.
I remember, probably like most of Australia and for our international colleagues, there would have been a point in time for all of them as well. I remember when our government had to make that first announcement of lockdown for our country, and what we thought as a service is, what can we do to remind the sector that Dementia Support Australia, seen as an essential service, so able to continue providing services across Australia on the ground regardless of the pandemic, because behaviours don't go away just because there's a pandemic. So we did a lot of work in ensuring that people remembered that we were here. So we had our staff call 1,000 aged care homes just to touch base and have a chat. We sent out some resource packages to aged care homes and hand delivered a range of those just to help people feel connected. And they included resources, hand sanitizer, and some little gifts to help them get through what was a really difficult time and continues to be a difficult time, not only here in Australia, but across the world. And we really made great accessibility of our video conferencing platform. So our preference is always to get on the ground, isn't it?
Yeah, definitely.
But in times like this, sometimes video conferencing is the only way that we can maintain that assessment and support for a care home. So we've certainly increased the accessibility and availability of that. And that's been a great addition to our services. We had some great help sheets created during this period of time as well. They're available on our website if you wanted to download some copies, but they talked about things such as what to expect when you're visiting someone in a care home, or if you can't visit during lockdown, what else might you do? We also talked about what to do when there is an outbreak in a care home and you've got people with dementia. What are some of the tips and techniques you might think about to support them, to ensure that they have a really good quality of life, because it's a really hard time when families can't visit. So I encourage you, if you haven't seen these, to pop over to our website or visit our exhibition page on this conference platform and find those. And so we're talking about there was no interruption to our service at all. We continued a seamless service all the way through. And we actually had really unprecedented demand from that late March into April period that has continued steadily over time, hasn't it?
Yeah, we didn't know if that was going to be the case, but week on week it's really stabilised, and it's higher than really we've ever seen before.
And I think that's really great that care homes feel able to reach out to services like Dementia Support Australia. We're funded by the Australian government. We're a free service. So it's really important that when you need us, you know you can reach out and contact us and get the support that you need. So we're really happy to share the findings of our service with any of our international colleagues, because we think this is a model that would work in different countries and different regions. And certainly we've tried a model across the UK earlier this year during the pandemic, and some of our colleagues are also talking in an on-demand session about Dementia Support UK, which is a video conference model that provides behaviour support into care homes in England, in the UK. So I just want to thank you for joining us and remind us that if you're in Australia, you can contact us 24 hours a day, 7 days a week at dementia.com.au or on our 24-hour helpline number 1800 699 799. Thanks, Tom.
Thanks, Mary.
Thanks, everyone.